the Indian subcontinent. He is like a jet engine who has pushed this modality over the years, from the early years of it being radiculated, and today where it already accepted and self-implemented in most of the cancer care centers in our country. Now, one, CA breast is what we are going to talk about. 1 in 8 women in their life is going to experience this unfortunate condition. And PET has got many roles. Dr. Rangrajan would be talking about it, but as I have been given 2 minutes, so, I need to say that we have got a good load and our surgeons are very accommodate that way to refer these patients quite frequently to us, even medical oncologist, even the radiation oncologist. So following the Tata Hospital practice, possibly, and other, initial centers within India, we have got a pretty good experience and good acceptance in our clinical practice here with PET-CT and CA breast. Without taking much of time, I would ask Dr. Venkatesh Rangrajan to please talk on the role of PET-CT scan as a whole body scanning for carcinoma of breast. Thank you, everyone.
Thank
Dr.
you, sir.
Rangrajan, sir. Yeah, please.
Yes, sir. Yes. I'll just start with the recording, sir. Can you hear me?
Yeah, very well.
Okay.
Yeah, we can
I'll
hear
just start with the recording. At the end of a recording, Dr. Manas sir will give a comment or comment about this lecture, and after that we'll take a questions from a chat, or we will tell the participant to directly ask the question to Dr. Manas and Dr. Rangrajan, sir.
Sure.
Thank you, sir. Thank you.
Very commonly discussed problem, which has still not got the final answer, which is the role of whole body PET-CT scan in breast cancer. So how to take up this discussion today? So I thought, let's first review on the so-called the biblical document of all the oncologists, whether it's the surgeon or the radiation oncologist or the medical oncologist, the NCCN guide. And this is the latest version of the NCCN guideline for breast cancer, released on September 13, 2021. So I had to copy and take some extracts out of these to make this talk relevant. And I find it extremely difficult to do so too. So let us now look at some of the important changes which has been highlighted. And first thing is that the additional tests which are recommended is the chest diagnostic test with contrast, abdominal pelvic diagnostic CT, or with MRI with contrast, bone scan or fluoride PET-CT. They have been clubbed together as a single category, and FDG PET-CT has been optional, and breast MRI also has been kept optional, but nevertheless, these things have been recommended. So this is more or less what has been for the last 3 years. Now, this slide and the next few slides are going to be about some of the modifications which have been suggested. One such thing I have highlighted is the breast MR. So a lot of emphasis being given on MR on the whole, and breast MR in particular. And then there has been some modification of FDG PET-CT. Well, there are many, just reading out a few. FDG PET-CT can be performed at the same time as diagnostic CT. FDG PET-CT is most useful in situations where standard imaging or studies are equivocal or suspicious, may be helpful in identifying unsuspected regional nodal disease, distant metastasis, something which we all know. Rather, I would use a better term, a more colloquial term. The hesitancy towards PET-CT has somewhat decreased. There is a slightly better acceptance of PET-CT. That's what I am able to gather. You might say that I am biased because I'm one of the earliest users of PET-CT. But if I were to go by my own personal experience and also the experience as a purely from an imaging science point of view, with around close to 18 years of using PET-CT or FDG, definitely I'm a big supporter of this particular product. There is another footnote modification. PET-CT can be performed at the same time as diagnostic CT. This is something which is very interestingly funny for me because I'm sure my other colleague who is also in this meeting will accept. We have integrated diagnostic CT along with FTT PET CT long time back, so almost more than 15 years since we have actually done that. So whatever is new, apparently is a new instruction, but it's not new for us. A little bit more bone scan, which has been recommended interval modified for chemotherapy every 4 to 6 cycles. And PET CT, fortunately, they have removed from the word optional as clinically indicated. So again, PET CT is becoming more recommendable, more acceptable. And also, they have now used they removed the word optional and they included PET CT. And rather, again, the same situation, the bone scan and fluoride PET seems to be synonymously used. Although they are entirely two different modalities, two different techniques with great differences in the cost, nevertheless. And in the case of stage 4, the M1 disease or in recurrent, there is again three field abdominal pelvic diagnostic CT with contrast or MRI with contrast. MRI with contrast. We'll talk about it later on when we are discussing one such scan. That's because MR, when you study MR, you can actually get a glimpse of the marrow also. And marrow being one of the early sites of metastasis. That was possibly the intention of using marrow, MR. But MR is 2 regions versus the 2 regions diagnostic CT. The cost is almost 3 times. Then brain MR, if you have suspected brain lesions, and again bone scan or fluoride PET and FTT PET CT, of course, they have been kept optional in this particular case where I feel the impact has been possibly will be the highest. So a lot of emphasis on diagnostic dedicated breast MR testing, although to put it in a nutshell, it increases significantly the sensitivity, but the specificity doesn't improve anyway by using MR. And that in fact creates, I feel, sometimes it creates more confusion than actually gives you solution. So again, talking about monitoring metastatic disease, there has been a greater emphasis of using PET scan and bone scan. And in the case of inflammatory bone scan, included breast scan, again, they have been lenient in using FTT PET CT. Some of these recommendations. Keeping this in view, I do not know, many of you might have even not seen this document which I just showed, but nevertheless, that's the thing. So now let us go into the depth of each of these modalities. First, let us look at the bone scan. Bone scan, I myself have practiced bone scan for the last 30 years. And bone scan per se is pretty old. It's almost my age. And clinical bone scan has been, especially this is a planar bone scan. Planar bone scan has been the mainstay of oncoimaging for a very, very long time. Extremely sensitive, not very specific, but it has been, and because in the absence of other competing today, whatever are the good modalities, earlier were not there. There were no CT, there was no MR, but bone scan was very much there. So bone scan was very, very important. Somehow that has stuck into the mind of many of the so-called old ophthalmologists, which I don't blame them entirely. So let us take it in the pinch of salt. Now I will start telling you something bad about bone scan, planar bone scan. It can pick up good osteoblastic metastasis. Its performance in osteolytic metastasis is almost zero, very bad. And mixed lesions, the response is highly variable. So when we talk of using it in breast cancer, this is something that everybody harps on. But as an imaging, as an nuclear medicine physician, I get very, very skeptical of using this particular product, especially the planar bone scan. So you are likely to miss a lot of business. That is the net important carry-home message. The next better modality is using a SPECT, especially a whole body SPECT. It takes quite some time, up to 45 minutes, 1 hour of patient lying down quietly. And if we have the resource, we can spend some more money and do a whole body scan. But that again doesn't improve the sensitivity and the specificity significantly. However, when you use fluoride is one of the earliest PET agents, sodium fluoride, a PET agent. It was also cleared along with fluorodeoxyglucose. Late 80s to be very clear. We have cleared. And why is it that this has never made a big impact? The reason is, now, for example, in this particular case, we are able to see it extremely well. We are able to see that there is multiple bone disease involved in the axial and appendicular skeleton. But many times things very good performing fluoride scan is not, and especially if it's a growing skeleton, and also in some, we are not in a position to identify whether it is a benign lesion or a malignant lesion in many situations, unless we have something to add for which we need the CT scan. Now that PET scans have gone, and now it's only since the late early 2000s that you have had FPG PET CT. Earlier we had only FPG PET, we didn't have a CT. So now after the CT has made its presence, fluoride has started. And in fact, we have been using fluoride since 2004, 2005, fluoride PET CT. So we actually have an excellent experience and we have used it extensively. So we conducted a small experiment on 100 patients, where these patients were all referred for conventional bone scan. They were the planar bone scan. And we also subjected them to a good whole body spec scan, which takes around 50 minutes. So we are not talking about the cost, we're just trying to do that. And then the patient underwent a fluoride PET the next day. So here there is no CT component, just comparisons. And what you realize is that over the modalities, the same modalities, we are able to identify much more lesions in the fluoride PET. But the equivocal lesions, which are many in the bone scan, it decreases in the fluoride PET. And when we integrate them with CT, we find that the equivocal numbers are not coming down significantly in the case of bone scan, but it definitely comes down in the case of fluoride PET CT. So this is a very good thing. And even if you take the osteolytic lesions, the mixed lesion, 58 and 192. So if somebody is hell-bent on harping that he would do only a bone scan for breast, I would recommend it. Please don't do a conventional planar bone scan of MDP. Do a fluoride PET. And then there are other aspects: availability of fluoride, the cost of fluoride PET. Fluoride PET CT, just because it's fluoride PET, cannot be done at a throwaway price. Technically, or I mean, if you do sensible costing, it will cost you almost 60% of that of an FPG. So today, when FPG scan is whole body, FPG scan is 20,000 rupees, and ideally a fluoride bone scan should cost around 15,000. So it's not a very sensible thing. If you go by the NCCN guideline, you will have to do a fluoride PET, which is around 15,000 rupees, and then you will have to spend around 8,000 to 10,000 rupees for doing a 3-week and CT scan. It's actually going to be much more expensive than doing a whole body of PET CT. And also, I'm talking about whole body PET CT or contrast analysis. So, just one table to show you the significant difference between sodium fluoride and NDP. So, one big advantage of using sodium fluoride PET scan is that the scan itself can be finished very fast. Although recommended dose is 6 to 10 millicuries, one could do an excellent scan with just half of this recommended quantity, and the scan could be done as early as 30 minutes after injection. So within an hour, the patient can go home, and the scan is of extremely good quality. There is no need to do additional view, rotation, etc. All those things which are, and the radiation burden is also approximately the same. So on the whole, if you have fluoride available and you have MDP available every day, fluoride scan is a better scan to do. So this is a good way of, this is a good example of showing fluoride PET CT, which shows osteolytic lesions with a lot of degenerative disease and also some osteoblastic disease and also some expansive plastic disease. So very good to use in some of the diseases like breast and others. Also, when you have CT, whether it's a fluoride PET CT or it's an FPG PET CT, the CT component itself can be used independently for looking at bone mineral densitometry as for getting the PMDT score. Somehow this has not taken off well in our country, I would say that, but it's so easy to do and it is so reproducible, and there is nothing called a gold standard. Because what you do it at the beginning of the treatment and later on when the patient is put on aromatase and other things, you can use the same technique for follow-up. And for just getting the BMP score, you don't have to do a whole body scan, you just have to do a small regional scan with CT. And what I'm trying to say that this piece of information, very valuable, can be made available along with fluoride PET or FDG PET CT. So now this is my campaign slide where I'm talking about what all the PET CT can do. Well, we all are using CT for a long time. So we are all knowing very much about CT. It gives you size, morphology. So contrast enhance, it gives you the enhancement pattern. And once you have enhancement, and then we can use the what we call as other indices of attenuation, and therefore we can get other indices like Choi index. And it PET, you get functional information, you get functional volume. Functional volumes are something with radiation oncologists will immediately relate to the SUV, if you all are knowing, but point is that SUV is not a single point. It's a collection of points. So it's sometimes you do not know whether to use the max SUV or you have to take the mean SUV and which unit of SUV would be good. But whatever it is, as long as you use the same treatment is good. Then there are several semi-quantitative cases where you try to describe the uptake in a particular region related to some other organ uptake and we can use such indices. We are using that in neuroendocrine tumors. We are using them in lymphoma assessment. We are trying many treatment responses. So this gives a lot of information for the physician. So PET CT, some people argue that PET CT is nothing but a CT scan with an FDG enhancement. Well, the problem is FDG per se has got such a varied biodistribution that one needs to think like a biochemist or like a MD medicine person. Only then he will be able to report the scan with a reasonable amount of specificity. It's a very sensitive modality. Anybody can see it and report it. But if you want to get a good specificity, then you have to you cannot go by this dictum. It's a CT scan with an FDG enhancement. On the quite contrary, it should be looked at in a different way. One should understand the disease and see the person looked at, treated. And this is one of the early fallacies that was identified both in the Radiological Society of North America and also the nuclear medicine community. When CT scan, we were replaced with PET CTs and people were reporting PET CTs like the CT with an FDG enhancement. There were lots and lots of false positives which gave this good modality a very bad name. So this is one of the reasons that why NCCM was feeling very skeptical to adopt this. Now things have definitely changed, at least in our Indian context. It's a different feature. We have adopted PET CBCT. We have adapted with PET CBCT very well. Well, PET CBCT initially as a single modality because the instruments, scanners were capable of doing both the contrast and the PET in the same sitting and the same scenario were made available after 2006, 2007. And we were one of the earliest departments to adopt this modality. And also there were several institutions in Korea, China, which also were doing so. PET and CECT all in happening in one place. Otherwise, the typical American story of PET, FDG PET happening in the nuclear medicine department, CECT happening in the radiology department, and somebody reporting them as separate, two interpreting some other centers. They are done as a single study, but reported by two different communities. I've been somewhere, there has to be some rationality. And many people have brought about a lot of standalone regional CECTs also. At the end of the day, the fact is most of the CECTs are regional CTs. They are all designed to perform optimally when it is done in a CT, and not like a whole body CT. So this is not something like even for a well-established radiologist, there is a big learning curve if he wants to translate into contrast CT of PET CT. But this can be used for reporting the RECIST criteria, RECIST 1.1 criteria, RECIST I versus name it. Whatever may be the response evaluation criteria you are talking of, this is achievable without any big difficulty. And now as the days pass by, with artificial intelligence and other advanced computing techniques, these things are very easily doable. All these numbers and indices and values and things, when you compare with the current study, with the previous study, it will give you a trend. So whatever is possible, these things are very good tools for the medical oncology to make you very happy. So this is all very nicely available. Okay. So this is one of our good scans to show you that how a PET CECP is done. Now, another point is, should we routinely enhance with with contrast or not? Well, that's a matter of choice, but I would say that we have to image wisely. While that is a dictum in, definitely it's a dictum in the younger age group, but also from the best CA also has a big age spectrum. So just remember that radiation-wise, that if you don't do a contrast-enhanced PET CT, then what you would do is you will spend only around 5 millisievert of radiation. But if you do the conventional bone scan plus your multi-region CT, contrast CT as what is or you do a PET CECT, your radiation would be around 25 millisievert to 40 millisievert depending on the type of protocol. So nevertheless, this PET CECT is a very useful ball game. It is used very nicely in several diseases. So purely from an imaging perspective, NCCF wise. So let's go back to the early part of 2010, 2012. What are the standard of care? You do a bone scan, MDB bone scan, and a 3-region CT scan. And now when sodium fluoride was very easily available, and the PET scanner was capable of doing CT, we could actually do them all in one go. You can have a sodium fluoride scan and a 3-region CT scan. So the CT scan, which is used as a contrast enhanced CT scan, will be able to highlight, it will enhance some nodes, it will enhance the disease in the organs if there are. Okay? So little bit. But these things have not really benefited much, even in a classical solid tumor like non-small cell lung cancer. So I do not know why there is so much hesitancy in using FTP PET CT. But this protocol, we were using it in some tumors. One is breast, and second is GU tumors, and also in some bone and soft tissue tumors. And this is a very good way by which we can integrate. But over the period, the last say 10 years, most of these GU tumors have now been replaced by PSN and other agents, and also bone and soft tissue tumors. Now we are not doing fluoride. Most many of them are doing sarcomas are being subjected to FTP PET CT. So there is a big change in the trend that we are going for the integrated FTP PET CT at baseline, and the FTP PET C non-CT, which is the PET CT at the follow-up and response evaluation. So this is an example to show you post case of neoadjuvant chemotherapy. So let's look at a patient who showed a partial response and other patient who had no response. Well, there are lots and lots of publications from 3 zones of the world where people have looked at the disease and the response to the treatment of neoadjuvant chemotherapy. People have used agents like PCM-DB, people have used, and definitely FTP PET has been used in a very way. Well, I'm not knowing what is the practice and practice trend, but if one really feels that it's worthwhile to evaluate a patient, how he has responded to neoadjuvant chemotherapy, not just the morphology, then I think this is a very good way of doing it. And the current literature, this is a paper which is published, just come out in the last 2 months, talked about the prognostic role of baseline FTP PET CT, SUVmax and SUVmax change in patients with node positive breast CA after receiving neoadjuvant chemotherapy. And the delta is the rate of change of SUV has been an independent prognostic indicator for the relapse and mortality in patients with extremely positive breast CA who received a neoadjuvant chemotherapy. So this is an excellent tool to look at the outcome of neoadjuvant chemotherapy. So I have sum it up like that. This is an example to show that there has been no significant change, but you can even identify early progression. So, and this progression, this is a purely a metabolic lesion. So you might not even appreciate it if you had not done better. So, and also in some really bad disease like triple negative breast, this is an example of a complete metabolic response in a patient who has received 2 cycles post chemotherapy. So if you look at this a paper which is published in our European Journal of Nuclear Medicine Molecular Imaging, which talks of benefits and harm of implementing FTP PET-CT for diagnosing recurrent breast cancer. The prospective study this is actually from the Denmark group, and they have looked at purely from a diagnostic point of view. And what is the carry-home message is what I have mentioned. The sensitivity, specificity, and the area is 1.88 and 0.9, which means this is nearly a perfect imaging tool for addressing the issue of diagnosing recurrent breast cancer and identifying metastatic disease. So there is no other imaging modality as superior to this. And this is another paper, a very recent paper from the clinical nuclear medicine. It's a systematic paper which has looked at the impact of FTP PET, PET-CT, PET-MR on the staging, management, when it has been used in the initial staging modality of cancer. So I've just taken the same point. The conclusion has been current available literature suggests that the use of FTP PET, PET-CT, PET-MR leads to a significant modification of staging and treatment in newly diagnosed breast cancer patients. Therefore, there may be a role for routine clinical use of PET imaging for the initial staging of breast cancer. So this is the first major group which is actually vociferously providing data by a systematic review to say that we should be using it at the beginning of the study. And now, I'm going to now bring about two interesting papers from the United States, because ultimately NCCN has been written for the US and written by the US people. So it's not, although there is a French group which has done several nice papers on using PET-CT in LABC. They are from Europe, so let's not talk about them. So now we talk about only this part. Paper published in September 2020 in the Journal of the NCCN, and this is from the Bronx and Albert Einstein group. So where here people have tried to look at the clinical utility of PET in localized breast cancer before initiating preoperative systemic therapy. So here they have just repeated the same thing what they had discussed in the past. PET-CT is considered as optional in circumstances in which the CT bone scan is equivalent as suspicious. Now their argument, the reason for them to take up this retrospective evaluation is that prior studies has reported greater sensitivity of PET-CT versus CT of the body for the detection of regional nodal metastasis and distant metastasis, and greater accuracy versus bone scan. So with this preamble, they have started us to look into how this argument performs, and they have looked at a 195 patient study group. And if you look at it, there is a significant number, anywhere between 30 to 35 to 40%, where there has been an impact of using the PET-CT in the beginning of the treatment. One other important thing is they have looked at the cost estimates based on American cost estimates. And they are saying that the total Medicare reimbursement rates of PET-CT and CT bone scan was 1,604 and 1,670, which means actually if you did PET-CT as in the beginning of the treatment, you would actually be saving some amount of money. Okay. So the conclusion of this particular paper is that given the high detection rate and the overall performance, reduction in the radiation dose, greater patient convenience, and most important, the time, because it's a single modality, single study which is being PET-CT should be considered as an alternative to CT bone scan rather than considered as optional, and systemic staging is being considered. So one paper. The second paper is again from the US, but this is a multi-center analysis. But again, retrospective in nature, but multi-center analysis. And this is published in November of 2020, where they have looked at the procedure using PET-CT as the initial staging procedure for stage 2, stage 3 breast cancer. So here there are three major sites: the University of Southern California, Minnesota, Alabama, and Georgetown University, where they have all pooled the patients together and they have a big number. And what they have identified is they have created two groups. One group which received the standard of care, which is about 231 patients, and another group which underwent the PET-CT, it's a 298 patient group. And a very similar disposition, except that, of course, I'm not going into this. There's some amount of rationality, some race bias seems to have been brought about by the author in the discussion. Well, that I'm not going to talk about. But what we will possibly be discussing is that they feel that the false positives are one of the very important ones. So far, the people who were against bringing PET-CT as a standard of care in LABC, they were harping about the point of false positives, that PET-CT would bring about more false positives and more false positives to additional investigations, and therefore many good patients who would be denied of proper treatment. Exactly, it is the opposite which has been identified by these authors in this particular paper. They said that false positives was higher in patients with standard of care than PET-CT in all biological subsets. The ratio of false positives are highest in triple negative and HER2 positive, 2.5 and 2.1, because these subtypes are more common in younger women. Biological differences likely to drive the higher false positive rate in younger patients, and greater consideration for routine use of PET-CT may be warranted. So this is a very, very important point, which is just countering the common, I would say, the common bogey which we are hearing about PET-CT use in breast CA. So these are all I would strongly recommend that all of you can pull up this paper and come in the journal of NCC and people should read it. So nevertheless, I feel that on the whole, also they are talking about how quickly the investigation was done. They have shown that there is a very significant difference. The group which underwent PET-CT as the first modality, they were able to get started with the primary treatment much earlier than that of, because I think it's just one investigation which could be done very fast rather than actually having a multiple of infections. And also the cost, although there has been some amount of heterogeneity because of cost, because in some institutions PET was charged higher and some institutions the PET was charged lower, but nevertheless they have all agreed in principle that PET-CT approach was cheaper. So here we have three situations. One, the false positive rate was low, the time for treatment, the time for initiation of treatment was faster, and three, it was cheaper if you adopted the PET-CT. So this is the same American data from 3 American groups, and it is somewhat like randomization done, but in the retrospective setting. So nevertheless, you can say that there is bias and all those things. But I think there has been enough scientific presentation of the data. And this is, I was talking to you about this Dr. David Glory and other group. They are actually from the French group. These people have done a lot of work on trying to make LABC, the FDG PET-CT as a first modality. And they have been successfully able to do in France and that part of Europe. And so they have written sort of a summation to support this aspect. And also the overall cost of FDG PET-CT and CT plus was comparable, and driven by decreased biopsies and follow-up imaging. So on the whole, there's some things to support. Okay. Then there's another paper in the European Journal of Radiology where now so far I have talked about fluoride bone scan, fluoride PET, I have talked about FDG PET, all in this setting. And now let us think of a very common problem. Breast CA, bone mets is very common, or for that reason, metastatic disease is very common. And if this patient happened to be ER positive, we would generally give the hormone treatment and all, and we will just wait and watch. We just give these tablets over a long period till we see whether there is any progression, and then we would possibly take some corrective action. So here, this is a paper which talks about a very important prognostic factor in patients with estrogen receptor positive cancer. The role of combining F18 fluoroestradiol and fluorodeoxycholic. So here, basically, we need to do 2 scans. We need to do first a FDG whole body scan, and then we'll have to do a fluoroestradiol scan. Fluoroestradiol scan for all. Now I'm trying to talk about it. It's now it's approved by FDA. So in the United States, it's an approved drug. It's easily available around the world. And there is something called cartridge, and so it's very easily makeable, and it is available in India. Okay, there are companies who, if you want, they will supply fluoroestradiol. So now, when you have fluoroestradiol and when you have FDG, how these authors have used it? They found that when they use this FES and FDG, they were able to look at the heterogeneity and therefore they were able to identify the heterogeneity in the bone metastasis and appropriately make treatment changes. Very nice depiction on scans. So you find here multiple vertebral metastases on the FTG scan, all of them showing good estrogen uptake, fluoroestradiol uptake. And when the patient took the hormonal treatment, the patient showed a complete response. Posterior therapy scan showed the whole thing was negative, a very good response. Now we look at this patient. This patient hardly has any uptake in the vertebral lesions which are picked up on the FTG scan. And obviously the treatment has not helped this patient at all. But if we knew this, we don't have to wait for a long time for this patient to continue to suffer, to progress, or to have additional comorbidities like a fracture. And we would have initiated the treatment, like, we could have gone for a spot radiotherapy, or we could have gone for a systemic theranostic agent like a Severian EVT or some other form of treatment. So fluoroestradiol is very much available, and it is something which we all can use it. Cost-wise, it is just a little bit more expensive than FTG. That also only the radiopharmaceutical. Another important isotope, radiopharmaceutical, which I thought that I should share with you, is the gallium-68 DOTA Zol, or the Zolindronate. Zolindronate, I think all people who are practicing breast CA, they are very happy to use this one, because the metastasis, the mixed lesions and osteolytic lesion, this is an anti-osteoblastic activity. So you can give zolindronic acid, and we just are very happily we prescribe this. And patient generally does very well. But please remember, zolindronate is not a very holy cow. It has its own adverse effects, and sometimes it can be very, very counterproductive in some situations. So here there is a scan of a person, this patient, on an FTG scan. We find that there are multiple vertebral lesions. And those vertebral lesions, when we do a gallium zol scan, shows a better uptake in the vertebral lesions, which means the zolindronic acid, this is a much small quantity of zolindronic acid labeled with this isotope, is able to show a very good uptake. And therefore, we can now, this is a theranostic approach. What is theranostic approach? I used gallium DOTA-zol to localize this disease. Now I can change the gallium, and I could possibly put another isotope, a lutetium or actinium, and that in the form of a DOTA-zol would go and selectively irradiate these lesions. And if I use actinium, it will irradiate only the bony card and it will completely spare the marrow. There are many people in US who have tried to give radium-223 for prostate CA, but also they are given for breast. So it's very similar, of course, but this is very, very focused. So this is another very good product available in India now, and this can also be put to use. Some of the last product which I want to introduce today is the FAPI, which is called the fibroblast activation protein inhibitor. This is a theranostic agent. This fibroblast activation protein inhibitor is a very important member of the tumor microenvironment. So far, we all have been targeting only the calcification, microcalcification, but now we have been able to successfully target the fibroblast activation, because this is something it's labeled with bifunctional chelate and labeled with gallium or fluorine 18, and we can image them using the PET scan. And we can, whatever we see as concentration, we can just change the isotope and even treat them. So this is going to be a big game changer, and I would say in another maximum 2 to 3 years, we will be having this as a very important player in our discussion. So now let us go back to our NCCN document from where we actually started our discussion. So one thing which rather irritates me is that, to look at the type of references which they have selected, they are all old references, papers published in 2006, 2008, 2007. When a paper is published in 2006, obviously the paper is written on the data which was collected in 2 years back, 2004, 5, which is the first generation of PET-CT, and many of these papers have been written that PET was done as a standalone model. There was no CT at all. So obviously there will be a lot of false positives, the overall accuracy will be poor. It's just like saying that, today who talks about lymphoma? We don't do a CT scan for a lymphoma because we have adapted and accepted PET-CT so much. The same way, all these things are, fortunately, they're low. 3 years, they do something fantastic, So they are able to, PET-CT acceptance has been very good in that group, but somehow here, and this could be one of the reasons, such outdated publications being given a lot of them. And you see the latest publication I can see is something in 2008. So this is the type of data, and now I have just shared in my talk very recent publications and the research material. So obviously, I think so. We should once in a while not hesitate to deviate exactly what is being done, or let us accept what the NCCN is trying to say. It was very, very reserved against PET-CT. Now it is not so reserved against PET-CT. It doesn't mind if you do PET-CT. It says it's okay if you do PET-CT. So let us use our common sense. And as an imaging specialist, I would say, I very strongly recommend FTG PET-CT at the baseline of all the breast CAs, locally advanced breast CA. I call it high-risk breast CA. And FTG PET-CT for response evaluation, and FTG PET-CT for restage. Of course, sentinel node biopsy with isotope and fluorescence are something which cannot be replaced, and therefore it is very important. So this is the first set which I feel we all should not hesitate to use from tomorrow. Now, availability of fluorohistodio, Dotazone is very much there, and we should again use these. And these things are really going to be a game changer. And of course, FAPI is going to be a game changer across several tumors, several solid tumors. But I'm sure we are going to have a good time. I thank the organizers for giving me a good opportunity to share my thoughts, and I'm ready to take all the questions. And I look forward for a very good, interesting discussion.
Well, Dr. Rangrajan, thank you very much. It was a very informative talk. Just because I have to add something and say something at the end, I would like to just say that we have found it very promising modality for the initial staging, especially in the extra-axillary lymph nodal diagnosis, especially when we try to diagnose infraclavicular, supraclavicular, and internal memory regions. Also, would like to bring in the concern that in stage 3B and above tumors, there is a possibility of almost 40% of these presented initial for PET-CT as staging, systemic staging modality, that patients could have distant metastasis, which was not seen because the patients were asymptomatic. So it has the power to impact the clinical management. As far as the monitoring of the treatment is concerned, now we have got very good medical oncology agents, chemotherapy agents. So there is a concept of stage migration. So early on, after 1 or 3 cycles of the chemotherapy in a neoadjuvant or adjuvant setting, we can use the PET-CT scan, and this could be very helpful in restaging the patients. And of course, as far as suspected recurrence is concerned, especially in locally advanced or cases where RT has been given and then the patient is on follow-up, it becomes quite challenging for obvious reasons for the conventional modalities or common modalities to diagnose. So in that particular setting, we see the usefulness of the PET-CT. And again, sir, thank you so much for highlighting us the new tracers which are likely to come, especially the FAPI and other tracers, receptor tracers that you just mentioned. And we look forward that they are easily available to us, and we at tier 2 and tier 3 cities all across India could follow you, do things which are required. Dr. Bhavna, if how are we going to do with the questions? How is it? Somebody is going to read the questions, ma'am?
Yeah, you can also read the questions. There are 3 questions, and we have got a very senior consultant there available.
Madam, I think if you ask it somewhat, we are used to asking surgeons, the questions, we feel more comfortable to answer them. So why don't you ask?
No,
Yeah, please.
You read from the chat box and you can ask directly.
Yeah. So who is helping us, ma'am? I can't read it at my.
Yes, I think there is a question.
Maybe. Yeah, madam, please. Yeah, please go ahead with the question. Yeah, sir.
Dr.
I will take many of these questions. But many of
so Dr. Rangrajan has to come live if he could be seen, because we don't
actually,
see.
If you come out of this, like you are
great.
doing a share screen, If you come out of the share screen, then I can be, you can see.
Sir, yes, I need to stop the sharing.
Correct, correct.
Okay.
Yeah.
Okay, now we are live.
Great.
So good. So let us take some of these questions. They are very interesting questions. So let me take the first question. Your views on SUV utility in clinical practice and limitations. As I told you, SUV
Sir, you have to
is
get
just
your speaker a bit close to your.
Can you hear me now?
Yes, now it is so nice.
Yeah,
Now it's
yeah,
the
yeah.
typical Dr.
So
Rangrajan.
basically,
Audible.
SUV is just as it's a semi-quantitative measure. Okay, so it has got no absolute value. That means it is earlier. I'm talking of way back in 2003-4. People were trying to, without doing a biopsy, they wanted to diagnose breast CA by doing this SUV and something called a dual point imaging and all those things. Per se, for the diagnosis of breast CA, SUV is not going to be useful. But when we are monitoring a disease or when you are monitoring the metastasis, SUV is a quantitation of the quantum of the sugar uptake, the FDG uptake, which is a measure of the amount of GLUT expression or a measure of the wildness of the malignancy. So from that point of view, SUV has an indirect measure. But for the radiation oncologist, he can use SUV based and he can use SUV in that way. So it has got no absolute value, it got a lot of related. That's the question. The second question is triple negative cancer. Triple negative breast cancer has a much more wilder disease. So obviously the uptake of FG is much higher. And that is the reasons that, more or less, if you see, all the unless there are some very low, only they don't show adequate amount of FDG uptake. Triple negative breast CA is a very classical case in which shows extent uptake. So I would say, we always say any good looking scan is not good for the patient. From that point of view, it is not. Role of PET-CT, generally the yardstick, we don't do extensive imaging in early breast CA. So here I would put the question in a different way. I'll put the answer in a different way. If the early breast CA is from a patient who has a higher grade of biological tumor, or there is a local inflammation, inflammatory breast disease, then there is a role of FDG PET. In a garden variety IDC, which is a small volume CA, you could use the conventional PET-CT would be required. Go ahead with your sentinel node imaging and go ahead. For bone metastasis, how does bone scan compare with FDG PET? This is what I mind story. Any day is 100 times better than a conventional bone scan. So bone is worst, bone spec better, fluoride bone scan is better than that, FDG PET is the best. So technically, very pure osteoblastic, there is a very small fraction of them which are not seen, but they are not having any big prognostic value. Bad prognosis, a higher prognostic value is always attained with respect to the osteolytic and mixed type of genes. It is completely missed, but it will be 100% picked up on a whole body MRI or on a whole body FDG. So what benefit you in a whole body MRI? Benefit or the slighter benefit, you will get it by FDG, because you can detect an marrow abnormality on MRI, which is pertaining to a particular metastasis at the diagnostic scenario. Later on, when you are going to give some treatment and you want to see how it has responded, that in MRI will exist, but your FDG take will significantly go down. So the best modality for looking at bone metastasis would be FDG PET, especially when it is an evolved disease and you are looking at different response.
Hello, Dr. Rangrajan.
Yes.
Sir, we can't hear you that properly. If you could maybe possibly
Now,
Avi, now it are good. Yeah, very good.
The evolved bone metastasis concern, FDG PET is the best compared to From Ahmedabad, what is good? Bone scan is better or FDG PET is better?
No, there is no doubt now. I think these are talks that we faced it maybe 10 years back, where there was, issues pertaining to bone scan versus PET scan. Our oncologists are now pretty used to, and we have proven the worth of PET CT beam. But there are few conditions that we need to know, and limitations, just like any other modality has. Few subtypes like lobular carcinoma and other, they don't show that much of FDG uptake. So that is where we, in case if we know beforehand that we are dealing with a such type of subtypes, and also FDG may not be the required investigation, FDG PET scan, and maybe some other investigations could be used. And also those of us who have been using now PET CT scans over the years, if the disease pattern does not follow the typical staging and the pattern of the spread, and you are pretty used to looking at these nodes and lesions which may be infective, and especially tuberculosis, it's not that challenging to differentiate and write that in the report that this looks like. So even the infection part, possibly at some place, if some node pops out and which is not falling to the stage or follow up, it is not that complicated. So
you can, Manas, we can say that now the experience of using PET CT has increased to such an extent, an amount of publications and the knowledge sharing, that we are now able to diagnose or identify the false positive much better.
Exactly.
So final impression in the report, the false positive rate is very low. I think, Manas, there is an interesting question. Somebody has asked, what are the technical limitations to get 3D reconstruction images with available PET CT scan? Here, my thought process is, I think the person wants to know the 3D recon with respect to CT. I think there's no problem in 3D recon in PET, we can get it. What actually happens is that if you want good 3D recon on a contrast for a vessel reconstruction or something like that, that particular region, you need to take the slices have to be very, very thin, and the contrast should be at the right, the contrast planning. That means the contrast should be at its maximum in that particular region. So this is something, especially if you are doing head and neck. So we can always plan it in a very nice way, and we can give you a recon of the vessels at that particular place. And also, and in the case of breast and thorax also, it may be technically possible, but I don't envisage the real requirement for it, but it is technically possible. If you really want vascular 3D reconstruction, you must inform the person well in advance, so that they are able to plan and re-slice and re-image all those segments much better. So that the acquisition, because the acquisition is generally in many places in order to conserve the radiation, we don't want to do so much of, we are not really planning from 3D recon point of view. If you want, you can always get it. That is not a problem.
So this is basically the job of an experienced technologist, and we have in every department. And there are software, CT-based softwares who do the job. And as Dr. Rangrajan said, that these are most commonly used in head and neck malignancies, where someone wants to know the bone depth of the bone lesion, and also in RCC, where one would like to use PET scan as the CT part of the PET scan as one-stop shop for the entire vascular imaging and other details, and few other cancers like HCC, maybe soft tissue sarcomas. But otherwise, in CA breast, that's not the case, because any advanced lesion which is going into the chest wall, and that is the structure we are worried about, has to be given a new adjuvant and then only be operated. And most of these lesions show metastasis, so surgery becomes out of question. Any other questions, sir? I can't see that, so because I am on mobile.
The last question was asked by Dr. KV and Raju sir. He is a senior surgical oncologist from Hyderabad. Raju sir, if you want to directly ask the question, you can again ask the question.
Good. So I've made that answer. If you want it, you have to tell it well in advance so that it is properly played.
Dr. Raju, long time.
Okay, sir. I just want to ask one question, that ER positive and PR positive patients have got a low uptake as compared to the negative tumors. What is the reason behind that?
Generally, that is the biology of the tumor. If you do, the ER, PR positives are relatively slower growing or slower multiplying compared to that of the triple negative ones. I just told you, and here we are measuring the GLUT expression. Please remember, We are not even measuring the rate at which it is multiplying. For that, we will use a thymidine scan. But here, what we are looking at is the way by which the metabolism of the glucose metabolism is taking place. So the more differentiated the tumor is, relatively less will be the uptake. And more undifferentiated or poorly differentiated becomes, more will be the uptake. So that is in that way, if you look at it, SUV, if you are comparing between 5-6 tumors, you can say the higher the SUV, you could possibly say that the biology is likely to be of a higher grade. Yes.
I think the same for the lobular carcinoma versus ductal carcinoma.
Lobular carcinomas generally show very poor GLUT expression. So lobular carcinomas, we will not be using it. But lobular carcinoma, now there are reports coming that possibly newer agents which are like FAPI and other things will concentrate. So we are not interested much about lobular carcinoma because you would agree that it is not anyway as violent as the ductal carcinomas. But generally, ductal carcinomas, as the ductal carcinoma is not one grade, it is multiple grade. As we are going with the grade, the FDG uptake increases. So
basically, if we know before, so if we know beforehand that it's a lobular carcinoma, it's a good idea to avoid FDG scans on that.
But Dr. Bhavna, generally what I understand is that as soon as you do a clinical examination, the first thing, at least in what Tata, our colleagues do, is then they take a, they would go in for a biopsy. They will take a core biopsy. Yes, once you have the core biopsy, it's going to be a matter of a maximum 3-4 working days. You will get a working diagnosis.
Correct, sir.
So once you have that, then automatically the risk stratification is done. You can very well plan who should go for a PET and who should not go for a PET. So I would rather say that, we can just wait for a few days and just one investigation PET-CT would possibly answer most of your questions.
Okay. I just want to ask a question about how is your experience with the fat necrosis? Because these days a lot of oncoplastic breast surgery and breast conservative surgery has been done. So the follow-up scan, if you do, and you can now will be able to.
Osteonecrosis per se will not show any abnormal FDG uptake.
But
if osteonecrosis evokes an inflammatory response.
No, I'm talking about fat
necrosis, the reconstruction she's talking about.
Yeah. So what happens is in a pure fat necrosis, we will not be able to see any major uptake of the tracer. But if it is evoking inflammatory response, or if it evokes a foam response, so then you will get a false positive. So that will be some of the drawbacks. So I would per se not be using PET-CT techniques for looking at these type of problems. I think you should be looking more at using ultrasound. That would be a better technique rather than actually.
Correct, sir.
Biopsy should be the first investigation if you are suspecting a fat necrosis.
Sir, your experience with the neoadjuvant, the preoperative hormonal therapy, then followed by the PET-CT scan, there was a trial also, the comparison of morphological and pathological response, early metabolic response of neoadjuvant endocrine therapy.
FDG uptake.
Yes.
Yeah.
Dr. Parikh, actually, I shared with you some of these papers. Okay. So it is a big thing in the Western world to monitor the neoadjuvant response and record the response by some form of a functional imaging. Earlier, they were using this gamma camera, MIB, which is what we are using for heart study. But now everybody uses FDG PET. But if you see that in many other centers, they just go by a general clinical evaluation and a morphological response. And they really don't believe in, looking at quantifying the response or looking at the P-glycoprotein expression and other things. So I do not know as to why it is. But generally, the answer for your question is there are excellent methods by which we can evaluate neoadjuvant chemotherapeutic response. But the question is, if you want to evaluate, then yes, there is method. And the best method is to do FDG PET, which is both quantitative and qualitative.
Thank you. So any other question from audience? Anybody wants to ask direct question to sir? We can unmute if anyone wants to ask the question. Dr. Raju, sir.
Good evening. Thank you.
Yes, sir.
So this question is to Dr. Rangrajan and Mayank. Good to see you.
Hi, sir.
So this is specifically in relation to the earlier question I asked is about the vascular anatomy. This is not related to the breast cancer. Vascular anatomy visualization, for example, in the pancreatic resections or in the hepatocellular carcinomas, we get good images with the 3D reconstruction with the conventional CT. But can we get a fusion image, the PET and the CT together?
It's very difficult, sir.
It's
The
difficult.
best answer to you, to be bluntly say, if you want the best reconstruction of the vascular anatomy, please do a dedicated three-phase CT of the pancreas, that particular region only, you will get an excellent reconstruction. Now, your question of having a reconstruction and then above that fuse it with the PET, we tried it, we could not achieve it. So I don't think at the present, because there are two, both of them are looking at two different type of dimensions, it's very difficult. So I would rather very strongly say, if you are using PET-CT, use them PET-CT independently to do the N and M staging. And where for the pre-operative, please take a dedicated small region, dedicated vascular scan and get the recon done. That would be my blunt admission to you.
Thank you for being so categorical, sir. Thank you.
So any more questions, Dr. Bhavna?
Dr. Subramanian Rao sir is also there if he wants to comment anything. Question, there is no question, but you can ask audience if anybody wants to ask the question. So it was an excellent talk again, as usual, as we are attending since so many years. And thank you so much for.
Thank you, madam. Thank you very much for calling me to Ahmedabad and sharing with the group of in Ahmedabad. I think Ahmedabad is one of the very lively and lovely oncology group. I have many friends there. So let the COVID get over and let us find an opportunity to meet again. And thank you very much, madam, for giving me this opportunity to share my time with you.
Thank you so much. Thank you so much.
Thank you, madam, and everyone who has joined in and made the conference CME worth.
Good night, sir. Good night, everybody.
Yeah, good night, Dr. Rangrajan.
Bye.
Bye, everyone.
Right, sir. Thank you.
Thank you, entire sir. Hari Om and thank you.